In this video, I'll be going through the principles of radiation therapy. Now, I'm a medical oncologist, not a radiation oncologist, but I'm hoping to be able to provide you with some basic understanding of radiation therapy. It is very interesting and an intersection of biology with physics and chemistry. So we went through the various situations of therapy in the curative setting versus the palliative setting, and the number of different specialists that are involved. And so, of course, we're going to be looking at the radiation component administered by radiation oncologists. We went through in previous videos the training that a radiation oncologist goes through, and that they are trained then in administering radiation in various forms. Usually, as you'll see, the most common is with external beam radiation, X-ray photon therapy, but also we'll touch on a little bit with proton therapy, as that is a common question as to what that is and where does it fit in. And we'll also touch on the differences in intention in the curative setting versus the palliative setting. So in the video on why and how we get cancer, we talked about a number of different environmental exposures that actually can cause cancer or contribute to the cause of cancer. And we talked about carcinogens that are mutagens, and actually that we leverage that understanding so that we can use chemotherapy to direct cell kill of actual cancer cells. And we also talked about how radiation can cause cancer, but also in this setting under controlled situations can be used to treat it. So what is radiation? Well, one form of radiation is electromagnetic radiation. It consists of waves of the electromagnetic field, as you can see here. And these waves propagate through space and carry momentum and electromagnetic radiant energy. And the differences in types of electromagnetic radiation, from radio waves to microwaves to infrared to the actual visible light spectrum to ultraviolet, X-rays, and then gamma rays, are all part of this spectrum, but are different in terms of their length of their waves, longer ones on the left, shorter ones on the right, and also on their energy levels, which I'll show you in later images. We'll be talking about the use of radiation therapy that are in the range of X-rays for the most part. So what is a natural source of these different types of energy waves? The sun, as you can see here, emits radiation along this spectrum, including, of course, the colors and the visible light that we can see, but also in the spectrum in the shorter and also the longer wavelength. This is flipped in terms of right-left compared to this figure, where the shorter wavelengths are on the right here and the shorter wavelengths on the left here. But you can see that the sun is a large source of this electromagnetic radiation. We'll also be talking about another source that are from elements that are unstable, called radioisotopes. A number of examples exist, including radon, uranium. We'll be talking about some of these as a form of treatment, like with yttrium. So what is radiation therapy then? It's a type of cancer treatment. We talked about the main pillars of therapy, including chemotherapy from a radiation oncologist, surgical therapy from a surgical oncologist, and now radiation therapy from a radiation oncologist. And there are different forms of radiation therapy. Again, the most common is called external beam therapy, which is intense energy that's designed to focus on and kill cancer cells. Some acronyms for external beam therapy are XRT or EBRT. Radiotherapy is often just referred to as RT. And it's administered through a machine called the Linear Accelerator. And I'll show you how that works in the next slides. So XRT therapy most often uses, as I mentioned, photons in that X-ray range of electromagnetic radiation. But other forms that we'll talk about here are particle energy, like protons and other types of energy like that. And they would just be having different machines that administer them. Again, another type of radiation therapy that's used is radioisotope therapy. Not much in gastroesophageal cancer, but we'll touch on it just so you're aware of it. And in some cases could be considered in liver metastases. And then finally, another branch of radiation therapy is called brachytherapy that we're going to go into. In addition to actual treatment with radiation, we of course use radiation in our imaging with CAT scans, X-rays, but also radioisotopes are used for PET scans, and I'll touch on that briefly as well. So how does radiation affect our tissues? So again, radiation is the emission of energy through electromagnetic waves that I showed you, are otherwise known as photons, or as moving subatomic particles, especially high energy particles like electrons or protons, either of which can cause something called ionization. And so again, on this spectrum of photons of electromagnetic radiation, the ionizing radiation is to the right, or with shorter wavelengths to the right of visible light. And again, X-rays are the predominant form that we're going to be focusing on here with respect to radiation therapy. And again, the reason why this is important is because I'll show you that ionizing radiation leads to DNA damage. So the different types of radiation are important to consider because the different wavelengths or the different properties of this radiation have different characteristics to be able to penetrate through our tissues. Shorter wavelength radiation can penetrate further through our tissue. And that's sort of a principle just to understand. And as an example, high energy particulate electrons can be used, as I'll show you, but they don't really penetrate deep into the tissues. And so they're usually used just for superficial types of cancers like skin cancer. On the other hand, cancers like what we're interested in the GI tract or in organs like the liver or the lung need to penetrate into our body. And so again, X-rays are really what we'll be focusing on moving forward here. So what is ionization? Ionization is the conversion of an atom or molecule or substance into an ion, which really means it's removing one or more of its electrons. And I'll show you an image of that to help you understand. And so the definition of an ion is an atom that has an uneven number of electrons and protons. So it has a charge. So this gets back to chemistry 101, where we look at this periodic table of elements, all the elements which are the building blocks of all things. And so remember, an atom is composed of protons and electrons and neutrons. And so the number of protons usually indicates where it will be listed on this table. So from 1 proton, 2 protons, 3, 4, 5, 6, etc. And then usually there's a similar amount or an equal amount of electrons to give it a neutral charge. And so, as I mentioned, everything in the universe is built of atoms as building blocks, and each of these are atoms. And so, as an example, water is made up of 2 atoms of hydrogen and 1 atom of oxygen, H2O. Oxygen is 2 atoms of oxygen bound together. Sugar, as you can see here, has 6 carbons, 12 hydrogens, 6 oxygens, etc. Even DNA, which we've been talking about as such an important thing when we talk about oncology, which was made of building blocks, those 4 bases we kept mentioning. When you look at the atomic structure, you can see that a segment of it is made up of 15 carbons, 31 hydrogens, 3 nitrogens, 13 oxygens, and 2 phosphorus in a specific 3-dimensional structure that's held together by bonds between these different atoms. So back to radiation oncology, and what we're really looking at is a linear accelerator, which I will show you an image of, focuses high energy towards a metal inside the machine that then bumps out an electron and ionizes that metal. And that leads to an unstable metal that releases X-ray energy. And that X-ray energy is then focused on the tumor. And so ionization, again, as we mentioned, is converting the atoms of this metal, in this case, to an unstable ion by bumping out electrons. In addition to this strategy, which is how external beam XRT works, another form of radiation therapy that we use is radioactive decay. And this is also known as nuclear decay or radioactivity, etc. And this is the process in which an unstable atomic nucleus loses energy by radiation. So in nature, there are a number of naturally occurring radioactive atoms called radioisotopes. This area in the table is enriched with that. For example, uranium, plutonium, etc. And so this instability of these atoms leads to a continuous emission of radiation. we will be talking about a specific atom called yttrium as a treatment in various cancer types, as well as could be considered for gastroesophageal cancer in some circumstances. In addition to treatment, radioisotopes can actually be used, as I mentioned, in imaging, and fluodeoxyglucose, or FDG, is basically glucose that has one oxygen and one hydrogen replaced with a fluorine. And this fluorine is an isotope of fluorine, which normally should have 9 neutrons and 10 protons, but this synthetically created version or isotope of fluorine has only 9 protons, and so it's unstable. So when this is administered intravenously into a patient, this molecule is like sugar, glucose, and will be taken into cells, particularly into those cells that are using more of it, like cancer cells. And then, because of its instability, it undergoes radioactive decay and emits energy. It emits a positron. And this is, of course, positron emission tomography, meaning we're measuring the amount of energy that's being released. And so wherever in the body this molecule is concentrated, like in cancer cells, this will light up on a PET scan. So back to the treatment form, though, and using a linear accelerator to generate X-rays. The first type of linear accelerators used for the metal that we were blasting the energy at as cobalt, but more recently, it is the atom called tungsten. And so this is a picture of the first patient ever treated with radiation with a linear accelerator with a cobalt machine back in 1957. This is a modern version of a linear accelerator. And as I mentioned earlier, electron beam radiotherapy can be focused directly at a tumor. The issue with electron beam radiotherapy is that it doesn't penetrate deep into the tissue. And so it can be used for superficial tissue like skin cancers. However, when we want to get deeper penetration, electron beams can be used in a linear accelerator to blast at a metal. As I mentioned, tungsten is a common one in these machines. And when that happens, it bumps out an electron from the tungsten atoms, and that creates instability that then leads to the release of extra energy from that tungsten in the form of an X-ray photon that then is focused at an area in the patient with the intention to treat the cancer. So once it gets there, how does this radiation work to treat the cancer? Well, whether it's from an inadvertent exposure to radiation in our environment, or if it's in the intention of radiation therapists who are focusing at a cancer, radiation affects our cells both directly and indirectly. Directly, radiation can damage DNA, but also indirectly, radiation ionizes and creates free radicals in water nearby that creates superoxide and peroxide that are damaging to the DNA. All of this leads to either irreparable damage and cell death, or the DNA tries to repair but is unable to, and then the cell dies. If, on the other hand, cells survive this bombardment and are able to repair enough to be able to survive, but there are changes in the DNA, these could be oncogenic. And this, of course, is why radiation in the environment can lead to cancers, and also why, as I'll talk about, radiation therapy, which is intending to kill cancers, can lead to the development of other cancers, because radiation can be affecting some of the normal cells nearby. This is an image just showing the same thing, but the actual biochemical formulas of what's happening in superoxide and oxides and how these can all affect DNA. So radiation therapy then interferes with DNA and DNA synthesis, and therefore it preferentially affects dividing cells. So this should sound reminiscent of how chemotherapy works. So it's a different mechanism of how we create the damage in the DNA, but it has the same consequence as chemotherapy. And in fact, it's just like when we talked about how different chemotherapies that each affect DNA differently can be synergistic when we add them together, like 5-FU plus oxaliplatin compared to each one separately. Similarly, chemotherapy with radiotherapy, called concurrent chemoradiotherapy, or CRT, is synergistic. Now, as I'll point out later, usually when combining chemotherapy and radiotherapy, the dosage of the chemotherapy is not as high as if it would be alone without the radiation. And similarly, radiotherapy can obtain higher maximum tolerated doses as monotherapy compared to in combination with chemotherapy. But that said, because they're acting in different mechanisms of DNA damage, together they're synergistic, even when the doses of each one might be a little bit lower than each one individually. So under the microscope, if we were to look at a sample that has had radiotherapy or chemoradiotherapy or chemotherapy for that matter, we can see different effects. And so this is an example, 3 different examples by column at low power on the top and high power on the bottom. And on the far left, we see an almost complete response with less than 10% viable cells, which is called a grade 1 pathologic response. So you can see in the blow up that there's still some residual viable tumor, but for the most part, the rest of it is just dead cells and scar tissue. In the middle panel, we see a response grade of 2, where there's still 10 to 50% of viable cells based on the pathologist's assessment, that there are still a number of different islands of tumor cells that are remaining, but a lot of it has been killed. And then on the far right column is the situation where we didn't see much of the response. There's still a lot of residual viable tumor that is remaining despite getting the therapy. But of course, with any of our therapies, whether it be radiation therapy or chemotherapy or immunotherapy, we want to see as many as possible grade 1 responses. So what is the difference then between imaging radiation and radiation that's used with respect to radiation therapy for cancer? Because in the end, it is all radiation. So X-rays, as I mentioned, are a form of energy that are on that spectrum, and they differ from visible light just based on their wavelength and therefore their energy levels. And so X-rays have shorter wavelengths compared to the visible light and radio waves. And as a consequence, as I was mentioning earlier, with shorter wavelengths, they have the properties and the energy that are able to pass through our body as opposed to visible light waves. And so for imaging purposes, again, we're still looking in that range of X-rays. And as the radiation moves through our body, it passes through our different tissues differently. So bones versus tissue versus air in our lungs will all absorb different amounts of the radiation coming through. And so when the radiation passes through, it's absorbed in different rates. So bone, for example, will absorb most, if not all, of that radiation, whereas lungs, a lot or most of it will go right through. And so in the video that we talked about how we diagnose cancers, I showed a lot of scans and showed that the black areas are where there's air or where the X-rays are passing right through, as opposed to, say, the bone, which was bright white, which is absorbing all the X-rays, and so it's not getting through. Ultimately, these differences in the way that the X-rays pass through our tissues is how the radiologist can create images of them and helps to delineate different structures in our body. And the amount of radiation that goes through the patient that the patient absorbs in all their tissues contributes to the patient's radiation dose, whether it's from imaging or from a radiation therapy that's focused in a certain spot. Radiation that passes through our body and doesn't get absorbed doesn't contribute to the absorbed dose. And so also recall that CT scans are just 3-dimensional images of X-rays. So an X-ray is a 2-dimensional image and doesn't really give us depth. But if you take a whole bunch of X-rays and put them together through a computer, we can get 3-dimensional imaging. The scientific unit of measurement for radiation, also called the effective dose, is called a millisievert. And there are other measurements for radiation that have been used, rad or RAM or sievert, but also relevant to radiation oncology is something called a gray. And the conversion of a gray to a millisievert is that 1 gray equals 1 millisievert. And that becomes important in the next slides. And so when we talk about treatment-based X-rays, they often overlap in the same X-ray range as to what's used for imaging. But the difference is that the image is a one-time dose, as opposed to treatment, as you'll see is daily for multiple weeks and therefore has a much higher amount of total radiation that would be absorbed by the patient. A common concern for patients that get imaging is this a lot of exposure to radiation, and is that harmful? And so in order to address that question, we first have to understand that we are always naturally being exposed to a background amount of radiation. There's natural sources. It's estimated that each of us has an effective dose of radiation of about 3 millisieverts per year. And some of that comes from outer space through cosmic radiation. And people who live at higher altitudes have less filtering through clouds and atmosphere. And so we'll have a little bit more than those living at sea level. And in addition, if you're in a plane and a higher altitude, you may have a minimally higher exposure to these cosmic rays. But ultimately, the largest source of background radiation that we are exposed to comes from radon gas in our homes, about 2 millisieverts a year. And so the important thing to understand is that the amount of radiation from, say, a single chest X-ray is quite small in comparison to even just our background radiation of 0.1 millisievert. So it's about the same as being exposed to just 10 days of natural living. And in this table, you can see then various types of imaging that we do, and there are approximate effective radiation doses in millisieverts, and therefore what it's comparable to our natural background radiation. So for example, a CT scan of our abdomen and pelvis with and without contrast, 2 different scans that are done, would be equivalent to about 5 years of exposure to natural background radiation. And the PET scan, as you can see, is a little bit higher, comparable to the background radiation that we would experience after 7.6 years of living. This is in stark contrast now to the actual doses that are used in radiation therapy for oncology for gastroesophageal cancer. So in the curative setting, a typical dose of radiation that's given to the G junction and esophagus is 50.4 gray, which is 50,400 millisieverts over 5 weeks. So that would be equivalent to 16,000 and change years of natural background radiation. And now remember, this is spread daily over weeks. Still, though, you can see the stark contrast in the doses of what is used in an imaging scan versus what's used for radiation. In contrast, as I'll show you, for palliative purposes, to just try and improve symptoms from an area, like, for example, a bone metastases, the doses are typically a little bit lower over a little bit less time. So there are a number of uses then of radiation in medicine that's shown in this figure. For treatment, again, the most common one is external beam radiation in the green and the yellow that we're going to be focusing on, but also we're going to talk a little bit about brachytherapy, and we're going to talk about the radionuclides, which are those radioisotopes that are undergoing decay and emitting radiation for treatment purposes. And in addition to that, we've talked about how photon X-rays and radionuclides can be used for imaging. Now, the doses here are much lower, as I showed you, compared to the treatment-intended radiation. So again, external beam radiation is seen here from a linear accelerator. Brachytherapy refers to, in the vicinity, an applicator placed in the area and left in place there, and then emits radiation just locally. So that's an example of brachytherapy in the esophagus. It's not really used that commonly, but there are reports and studies that have looked at that. And then finally, an example of radionuclides where those radioisotopes are used is in something called theraspheres or Y90 microspheres. And what is going on here is these little beads, these little particles, are labeled with a radioisotope, in this case Y90, and then this radio-labeled microbeads are injected into an artery right in the vicinity of a cancer nodule, like, for example, in the liver here. And this is referred to as transarterial radioembolization. And so these little beads come through and they get lodged in the small blood vessels right near where the tumor is. And then as they're lodged there, they're decaying and emitting radiation energy, and this can be damaging to the cancer cells nearby. So again, this is not commonly used in gastroesophageal cancer. It's more commonly used in other tumor types like liver cancer or other cancer types that have spread to the liver, like colon cancer. But there are reports of it being used in all cancers that have spread to the liver, including gastroesophageal cancer. But by far, external beam radiation is the most common form of radiation therapy that's used, and certainly the most common form used in gastroesophageal cancer. The next thing to discuss is the radiation oncologist and how they plan their treatment. And so on the left here, you see a planning simulation of an esophageal cancer, and on the right, you see for a stomach cancer. And so what's happening is the radiation oncologist is using images to plan where they're going to be shooting the various beams of the therapy. And so two modern common radiotherapy techniques include 3D conformal radiotherapy and intensity modulated radiotherapy, or IMRT. And what this is doing is it's using the benefit of where each of these beams are converging to really give the highest dose of radiation and to try and limit the amount of radiation that's going outside to the normal tissues. And so remember, X-rays come right through one's body. And so by doing this type of three-dimensional planning, the radiation dose where all of these rays converge would be highest. IMRT is computer-controlled X-ray accelerators that distribute precise radiation doses to malignant tumors or specific areas within the tumor. And so it's believed to be maybe a little bit more effective, although has not been compared directly that often to 3D chemoradiotherapy. However, there are a number of reports that suggest that IMRT has the potential to increase the number of radiation-induced second cancers later on. Overall, though, the most common things you will see as external beam radiation, or XRT, at various centers will be one of these or both of these two available at that center. There is one other form of radiation therapy that you will probably have heard of, and that's stereotactic radiation, which is also referred as stereotactic radiosurgery, or SRS, or which is really describing therapy that's done to the brain or spinal cord in the neural oncology setting, or SBRT, stereotactic body radiotherapy, which is to the rest of the body. These are essentially the same thing, as is gamma knife, cyber knife, and a whole bunch of other names that all refer to the same thing, which is basically just high dose focused radiation beams that are targeting a well-defined region. And so this is really used only for really small tumors, hence why it's used in the brain, for example. So overall, external beam therapy from a linear accelerator is the most common radiation that one would be considering with gastroesophageal cancer, and the most common types are going to be 3D CRT or IMRT. So now, where is radiation used? The first example would be in the curative intent situation, so a locally advanced cancer that's stage 2 or 3. And so as an adjunct to surgery, usually given before surgery, called neoadjuvant therapy, for example, with esophageal squamous cell, can also be used for esophageal adenocarcinoma and G-junction adenocarcinomas. And when we get to the video on perioperative therapy, you will hear my thoughts in terms of using perioperative chemotherapy alone without radiation versus neoadjuvant chemoradiotherapy and the pros and cons of each. But for now, you should know that radiation can be used neoadjuvantly, certainly for squamous cell esophagus, and is an option at the moment for adenocarcinomas. For stomach cancers, radiation used to be used pretty routinely adjuvantly after surgery along with chemotherapy. But a number of studies, as we'll talk about in a later video, really showed that there was no advantage to that. And so it's, in my opinion, no longer considered a standard or routine to give radiation therapy for the majority of patients having had a resection of their stomach cancer. In addition to as adjunct for surgery, we can use it as a replacement for surgery. So in the setting of esophageal squamous cell cancer, which is very radiosensitive, it's very sensitive to radiation therapy. In many cases, chemoradiation can lead to a complete response and spare the patient from needing to undergo resection. And so this would be referred to as definitive chemoradiotherapy without any surgery after. And the reason for that, of course, is because some patients can be followed and their cancer is completely eradicated with this treatment and surgery is not necessary. On the other hand, a definitive chemoradiotherapy would be considered for a patient who can't undergo surgery for various reasons, whether it's because they have a locally advanced cancer that's invading into organs nearby, like the trachea or the heart, or if a patient is not a candidate for surgery based on other medical problems or what we call comorbidities, or if a patient just doesn't want to go to surgery and understands the risks and benefits of it and has decided not to, then definitive chemoradiotherapy would be the next best thing. But similarly, for gastroesophageal adenocarcinomas, one could replace surgery, but currently the standard would be to consider definitive chemoradiotherapy without surgery only when surgery is not considered possible. For example, as I mentioned, comorbidities or frailty, poor performance status, old age, can't undergo a major surgery. Or, of course, again, if a patient refuses surgery. So in that latter setting, I would really make sure the patient understands that it's not optimal for adenocarcinomas, but that it's the next best thing. If we're really not going to go to surgery, then chemoradiotherapy was probably the next best thing to try and keep that primary tumor under control as best as possible. In contrast to the curative intent setting, we have the palliative intent setting where radiation can often be very useful. And so this includes in the setting where we're getting systemic therapy, whether it's chemotherapy or targeted therapy or immunotherapy, and where most of the cancer is under control, but one or a few areas are symptomatic despite the therapy. For example, it's not uncommon for the primary tumor to act up with symptoms, whether it be bleeding or pain or dysphagia in the esophagus. And so all of the metastatic sites under good control, but the primary tumor not. And so radiotherapy there could be helpful to help palliate that symptom and keep it under better control. This is actually not uncommon. And in many studies, we see that in the metastatic setting, about a third of patients, particularly with esophagus and G-junction cancer, will require this through their journey. In addition to that, there could be other sites outside of the primary tumor. A common site might be the bone, where it's symptomatic, where the rest of the cancer is under good control, but there's a bone symptom, bone pain, and so radiation to that lesion could be done. The duration and dose levels of therapy are different in the palliative setting compared to the curative setting, and you can see here some typical treatments like to the primary tumor can be over 10 to 15 days, often by itself, or it could be in combination with chemo for a longer course of the typical 4 to 5 weeks, depending on the intention of the therapy. And similarly for bone metastases, can be a one-time treatment that can significantly improve symptoms. This is an example on the right of a bone metastases in the vertebral column in the spine. And remember, the spine should be all white, but you can see this soft tissue mass, which is the cancer lesion inside the bone there. And that can be very painful. And so this is the planning of the radiation field. And so the other thing to note is that the field here is a lot smaller when you're palliating a very specific site compared to in the previous planning of a curative intent setting, where it has to include not only the primary tumor, but also regional lymph nodes nearby of which the cancer could spread to. So the curative intent window around the primary tumor is a larger field compared to typically the palliative treatments that will be considered. Other common questions are, why is radiation daily from Monday to Friday? And so we were alluding to that the dose is quite high, the total amount of radiation that would be given through the whole treatment plan. And so to give it all at one time would be too toxic. And so breaking it up over days helps normal cells to recover in between. And also the thought is that normal cells can recover quicker than cancer cells. And so the cancer cells are more susceptible, even though we're spreading it out over time. I like to joke with my colleagues that radiation doesn't work on weekends, and that's why it's only Monday to Friday. And also the maximum tolerated dose differs by tissue. So this is another thing to consider, and that is shown here, where in studies that looked at what is the highest radiation dose that one can tolerate in each of these different organs. For the esophagus, for example, is in the range of 50 to up to 70 gray, before you start to get symptoms like clinical stricturing or narrowing of the esophagus through fibrosis and scarring, or actual full-blown perforation or bursting of the esophagus. And so we know that there are limits in terms of about how much an organ can withstand. And similarly, in other studies like the stomach has similar, usually it's a little bit more sensitive even than the esophagus. Again, will have consequences if you go higher than those limits. It's important to note that these limits are lifetime limits. And so that gets to the whole question of, are we able to re-irradiate a field that was previously radiated? And we'll get to that in a later slide. So some other things to consider in characteristics of radiotherapy is that, generally speaking, the actual treatment itself is painless and very quick. You can't see the radiation. It's like going and getting an X-ray or CAT scan. You don't glow or emit light. It's not radioactive in and of itself when we're talking about external beam radiation. Of course, the brachytherapy or the radioisotopes I was talking about is radioactive inside your body, but it's targeted in a certain area. You wouldn't set off alarms in a store or at an airport. And in terms of side effects, which we'll go into more detail on the next slide, but a common question is, will I lose my hair? And the answer is no, not if that hair is nowhere near where your treatment field is. And so, for example, if we're treating the primary tumor in the stomach or the esophagus, you wouldn't have hair loss from the radiation. Similarly, you wouldn't have nausea or vomiting unless it is focused in the GI tract, which of course, in our case, it very frequently is. And we'll go into that in the next slide. Radiation therapy is not the same, though, as uncontrolled exposure to radiation, like with an atomic bomb or a nuclear meltdown. And that's shown here because it's in a controlled field, as opposed to in these situations where it's basically really high doses to your whole body. And you can see the doses and what would happen at each of these doses, where the red is really incompatible with life. And you can see at the other far extreme is where we have background exposure and imaging that we do routinely. And of course, the patient does not gain superpowers from radiation. So radiotherapy, it's very important to understand, only treats what is within the planned radiation field. And so it is a localized therapy, like surgery. When we get to the surgery video, it is targeting certain areas specifically. And so in the curative setting, it would be to the primary tumor and regional lymph nodes, as I mentioned. In the palliative setting, usually that window is much more narrow to limit side effects and to really hit the spot that's symptomatic, like the bone spot that I showed you. And finally, curative intent external beam radiation could be considered for something called oligometastatic disease. So it's stage 4, but it's minimal disease to minimal sites, preferably after a long period of time of control with systemic therapy without any new sites of cancer showing up. And if that was the case, then one could consider a more aggressive approach to the primary tumor and metastatic sites with radiation with or without surgery. And we'll talk about that in a dedicated video later. So with respect to actual side effects of radiation, because radiation in the primary tumor is usually reserved, and at least in my opinion, for the esophagus and GE junction for the most part, these are side effects that are specific for that, including inflammation of the esophagus, which is painful even to water, swelling in the esophagus with the radiation that can lead to worsening of the dysphagia problem, even to water. And so counterintuitively, even though the radiation is being used to treat the cancer, in the short term, it can actually worsen a lot of the symptoms that one presents with. And so that should be recognized. Also, skin changes near the area. So remember, this is like radiation, so it can cause redness in the skin and even browning or tanning. It can cause nausea and vomiting, as we talked about, when it is towards the GI tract, and also decreased appetite, weight loss, often make patients feel tired or fatigued. It can decrease the blood counts because our bone marrow in the bones within the field of the radiation can be affected. And postoperatively, after a curative intent surgery, can increase the risk of something called an anastomotic leak, which we'll talk about in the surgery video. But that's where the two ends of the remaining part of the GI tract are reconnected. And so this anastomosis can leak, and it has a higher risk of leaking after having had prior neoadjuvant radiotherapy. another thing to note is that these symptoms tend to lag after starting radiation. It's not after the first dose, it's not after the second dose. It's usually after you get into weeks of the therapy, 3-4 weeks, when this starts to hit its peak. And similarly, after the radiation course is completed, after say 5.5 weeks, a lot of these things take a few weeks to resolve. When given with chemotherapy, each of these side effects can be exacerbated. And that is something to also note. Now, there are certain side effects that are specifically from the radiation, like the esophagitis and the swelling in the esophagus that goes on, the post-operative complications with the leak. But a lot of these other side effects, you'll note, overlap with side effects of chemotherapy. And so it is sometimes hard to tease out which of the two, if not both, are causing this. And more often than not, it's a contribution of both of the modalities of therapy, both the radiation and the chemotherapy. In addition to acute side effects, which occur during and shortly after the radiation, side effects can occur later, or chronic side effects, which include esophageal stricturing or fibrosis if the radiation was in that field. And this is not malignant stricture, it's just fibrosis and scarring that's induced by the radiation. And this often requires repeated dilations to help with swallowing. Also, we can get development of second cancers in that radiation field. Again, because the radiation can change the DNA in normal cells, other cancers can develop over the next decades. Because the heart is in the field of the esophagus, and to some degree, there are a number of different cardiac toxicities that could occur over time. I mentioned about the low blood counts, where there are bones in the bone marrow in the field. This can lead to lower blood counts later on. And also the lungs can be affected with inflammation in the lungs called radiation-induced pneumonitis. This can lead to shortness of breath and other complications. And so all of these things need to be considered when we're talking about radiotherapy in the esophagus and GE junction. And as pointed out, the doses in the curative setting are higher than that would be in the palliative setting. And naturally, the higher the dose, the higher the risks of any of these potential side effects. We mentioned how every site in the body has a maximum tolerated dose throughout one's lifetime. And so the risk of re-irradiating a previous radiation site, for example, if the cancer came back in an area where there was prior radiation, there would be an even higher risk of all of these side effects, to the point where, generally speaking, it's not accepted and is not conducted. But that's a good segue to the next type of radiation therapy called proton beam therapy. And so this figure shows the difference between conventional X-rays in gray and protons in orange, where conventional X-rays come through the tumor and right out the other end of the body, as shown in this figure here. So it comes in, it radiates the tumor, but it also goes all the way through. And in contrast, protons come through to some degree, affecting the tissue beforehand, but then peak as desired right where the tumor is, and then fall off and not leave out the back part of the patient. And so the exposures are different. And so theoretically, proton beam therapy may be more targeted and cause less side effects. However, proton beam centers have been scarce, and at the moment there's only 41 proton beam therapy centers in the United States, and there are a total of 89 worldwide. And so as a consequence, most of the studies so far with proton beam therapy are small, retrospective, they're not definitive, although many of them do suggest that they are at least maybe better tolerated, have less radiation to the normal tissues nearby, and some suggest they might even be better. In gastroesophageal cancer, there's even fewer studies. There is one randomized study that was recently published that was comparing protons versus photon X-ray EBRT therapy. And first was that they saw that there was no real difference in progression-free survival or overall survival. And similarly, with quality of life questionnaires, there was really no difference. And there was also no difference in post-operative recovery after surgery. This was a study for patients with locally advanced esophageal cancer, both squamous and adenocarcinoma, and they were given either proton beam therapy with chemotherapy or conventional IMRT therapy with chemotherapy in a randomized study. That said, in a different way of looking at the toxicity using an endpoint called total toxicity burden, where they sort of summed up all the potential side effects and they graded them by severity. So on this figure, anything that's red is higher severity compared to blue. And on the top part are patients who had the conventional IMRT X-ray based therapy. And on the bottom are the proton beam therapy. And you can see just visually that there's more in the IMRT group slightly. And so whether or not that will be true in larger setting remains to be seen. But this study did lead to a larger phase 3 study, which is currently accruing and ongoing through the cooperative group called NRG. It should be noted, though, that as much press and excitement that the proton beam therapy gets, it's currently not approved by insurance and it's not recommended particularly in any guidelines. However, with some of the data that is currently available, maybe there will be potential uses. As I mentioned, for the most part, in my practice, I use radiation therapy for squamous cell tumors mostly. And in those that might recur locally after prior radiation, maybe reirradiation with proton beam therapy might be useful if it is truly lower toxicity and maybe get better control there. So in this video, I went through the principles of radiotherapy. We talked about what is radiation. We talked about the different forms of radiation therapy, external beam versus radioisotope versus brachytherapy. We talked about utility both in the curative setting versus the palliative setting. And we talked about side effects to be aware of radiation therapy. Thank you.